Hello, my name is Stefano Luminari. I'm professor of medical oncology at the University of Modena and Reggio Emilia in Italy. During the last ASH meeting at the late-breaking session, we were able to assist at the presentation of the first data of the inMIND study, which is an international phase 3 double-blind randomized study which evaluated the efficacy and safety of adding Tafasitamab, an anti-CD19 monoclonal antibody, to lenalidomide and rituximab combination in patients with relapsed refractory or marginal zone lymphoma. The presentation was devoted to the follicular lymphoma population, which represented the largest part of the patient and about which the statistical assumption of the study were built. So the study enrolled the patient were treated with at least one prior line of therapy containing CD20 monoclonal antibody, and randomization was between a standard one-year treatment of R² versus the same one-year treatment of R² with an addition of Tafasitamab at a fixed duration. The randomization was 1-to-1 and was stratified according to POD24, refractoriness to anti-prior CD20 monoclonal antibody therapy, and number of prior lines of therapy. The main study endpoint was progression-free survival assessed by the local investigator. 548 follicular lymphoma patients were enrolled. The two randomized arms were balanced in terms of the main characteristics of the patients, and the high-risk patient population were well represented in the study population, with most of the patient, 54%, being in second line of therapy. So the majority of the patient only received the one line of therapy. So this is the patient who were well balanced in terms of the clinical characteristics, with the subgroups of high-risk patients were represented in the study. The median number of prior lines of therapy was 1, with 54% who actually received only one prior line of therapy, thus making the inMIND study mainly describing a patient population in the second-line setting. The study endpoint, which was progression-free survival by investigator assessment, was clearly met, showing a superiority of the experimental arm, Tafa R² versus R² plus placebo, with a reduction in the risk of progression-free survival, which was approximately 60%, and with an improvement in the median progression-free survival comparing R² versus R² Tafasitamab of approximately 9 months. The study results in terms of the primary study endpoint were also confirmed in additional endpoints, including progression-free survival assessed by the independent review committee, time from subsequent treatment, duration of response. And in terms of overall response, there was only a trend which was not statistically significant in favor of the combination experimental arm. Looking at the progression-free survival data, results were consistent in almost all risk groups, and in particular in the 3 stratification factors that were used for the randomization. Including POD24 patients, refractory patients, and patients who received 1 prior lines of therapy versus those who received 2 or more prior lines of therapy. And finally, in terms of the safety profile of the experimental arm was absolutely superimposable and similar to that of observed for the standard arm. And looking at the grade 3 or higher treatment-related adverse event, there was only a mild increase in the rate of COVID-19 infections. We have to say that the inMIND study enrolled the patient during one of the peak of the COVID pandemic. There were actually 5.8% of patients who experienced a grade 3 or higher COVID-19 infection versus only 2.2% of the experimental arm. So in conclusion, based on the inMIND study, we have clear data that show that a combination of 3 agents, in particular 2 monoclonal antibodies, anti-CD19, anti-CD20 with lenalidomide, is able to improve the progression-free survival rates, reducing the risk of progression and death by approximately 60% compared to R square only. And considering the safety profile, the patient characteristics of the randomized population, I think we can state very clearly that tafasitamab plus lenalidomide and rituximab is a very good regimen that can be administered in the community setting and is particularly well suited for second-line rituximab refractory follicular lymphoma patient. Thank you for your attention.